Hello everyone, I'm Dr. Ashish Kuragai and today we'll be studying about clinical anatomy of the lymphatic organs. So the lymphatic organs are primarily divided into two types, primary lymphatic organs and secondary lymphatic organs. So you need to understand that primary lymphatic organs, they are associated with producing and maturing the lymphocytes, all right? So they produce and mature B cells and T cells. So there are two primary lymphatic organs, bone marrow and thymus. All right. So bone marrow produces mature B cells. All right. And T cells are also produced in the bone marrow, but the T cells are matured in the thymus. All right. So the bone marrow produces mature B cell. The B cells are matured, but they are naive. That means they are not exposed to the antigen and they are not activated. So they are mature, right? They are capable of being active, but they are not activated because they are not presented with an antigen. They are not exposed to an antigen. So they are capable of performing their function, but they are naive. All right. Now, bone marrow produces T cell as well, but the T cell maturation occurs in the thymus. All right, that's all you need to know. Now let's talk about secondary lymphatic organs. So the only thing you need to understand about secondary lymphatic organs is that they activate the mature B cell and T cell. So B cell and T cell, when they're matured, they get collected in these secondary lymphatic organs. All right, and when they're exposed to an antigen, then they are activated and then they are fully capable of performing their function. And then they differentiate into different types of T cells and different types of B cells. All right. So this differentiation and activation occurs in secondary lymphatic organs after being exposed to an antigen. So let's look at some of the most important secondary lymphatic organs. They are spleen, lymph nodes, tonsils, and Peyer's patches. So these are the most important ones. So antigen presentation occurs via antigen presenting cells. So for example, let's say antigen presenting cells capture an antigen in the skin. All right. So via the draining lymphatics, these antigen presenting cells come to the lymph node and present this antigen to the B cells and T cells. All right. Then they divide into mature effector cells. All right. The mature naive cells divide into effector cells. All right. Now, we have talked about bone marrow, and from exam point of view, that's all you need to know. It produces B cells and T cells, but B cells, when they are produced, are mature. T cells, when they are produced, are not mature. And this maturation of T cell occurs in the thymus. That's all you need to know. All right. Now, talking about thymus, this is super high yield from exam point of view. Now, one of the most important things that they ask in exam is the embryology. So you need to understand that thymus has two origins. The epithelium develops from the third pharyngeal pouch, all right, the endoderm. E for E. Epithelium develops from the endoderm. And it's the third pharyngeal pouch. Super high from exam point of view. Now, thymic lymphocytes, they develop from the mesoderm, all right? Epithelium from the endoderm and the lymphocytes from the mesoderm. So in exam, they'll give you a question about myasthenia gravis. And you know that myasthenia gravis is associated with thymoma or thymic hyperplasia, right? And then they will ask, which of the following is the origin of this associated organ. All right. So first you need to identify that the patient has myasthenia gravis. Then you need to associate it with thymoma. All right. Then they will ask you which of the following is the origin of this thymus. All right. So this is one way of asking a question in the exam. Now, the most important thing that you need to learn from this slide is the clinical relevance. So they will ask you numerous questions about thymus, all right? So you need to understand that thymic hypoplasia is associated with DiGeorge syndrome and SCID, all right? Severe combined immunodeficiency syndrome, all right? So they'll give you a clinical scenario of DiGeorge syndrome, all right? They'll tell you there's immunodeficiency, the patient has recurrent infection, the patient has hypocalcemia, things like that, right? And then they will ask you which of the following organs will be hypoplastic, right? Or they might give you that on examination, thymus is hyperplastic. Which of the following is the disease? All right. So there are numerous immunodeficiency syndromes, and the clinical scenario or clinical presentation might be similar. But this point that there will be thymic hypoplasia will help you to narrow it down to DJAW syndrome or SCID. All right. So DJAW syndrome and SCID are associated with thymic hypoplasia, super high yield. Now, another clinical association that they love to ask is thymic hyperplasia. So, thymic hyperplasia is associated with myasthenia gravis, SLE, and rheumatoid arthritis. So, I talked about myasthenia gravis earlier, but they will ask you a question about rheumatoid arthritis, and they might ask which of the following organs are hyperplastic. All right. So, they'll give you a 25-year-old woman presents with joint pain, knee swelling, stuff like that. And then they will ask you which of the following organs are hyperplastic. All right. Another super high yield point is thymoma. So it's a tumor of epithelial cell. All right. It's a tumor of epithelial cell. And like I said, myasthenia gravis is highly associated with thymic hyperplasia and thymoma. All right. And other disease associated with thymoma are pure red cell aplasia and immunodeficiency with thymoma. All right. These three are super high yield and associated with thymoma. So now let's talk about the structure of a lymph node. Now, this is afferent lymphatics. This is where the lymph node receives the lymphatic fluids, all right? So it comes from the afferent lymphatics and then it leaves from the efferent lymphatics. The lymphatic fluids come from here and leave through here, all right? Now, the most important thing that you need to understand from exam point of view is cortex, medulla, medullary sinus, and the follicles, all right? Super high yield. Now, let's talk about cortex. So, cortex is also known as the B cell zone. All right. It's called B cell zone because B lymphocytes are stored here. All right. So, the B lymphocytes are housed in the cortex. All right. So these are follicles, all right? Now this is a secondary follicle. I have not shown primary follicle in this image, but the difference between secondary follicle and primary follicle is that secondary follicles are the active ones, all right? And primary follicles are inactive. The secondary follicle has this pale germinal center. Can you see this pale part, right? Compared to this purple, this is a bit pale. So if you see a pale follicle, it means that it's the active follicle, all right? It's the secondary follicle. If this follicle didn't have this pale area, let's say there were this purple area only, let's say this pale center was not present, then that would be primary follicle. Now, follicles have B lymphocytes, all right, super high yield. So, lymphoid follicles are the sites of B lymphocyte storage, differentiation, and proliferation. The way the question is asked is B cell activation occurs after an antigen exposure, right? Let's say you get a bacterial infection and you need to produce antibodies against that infection, right? Against that organism. So B cell needs to be activated, differentiated, and proliferation has to occur to produce those antibodies, all right? So this activation proliferation occurs in secondary follicle. So this is how they will ask you a question. They'll give you a vignette of the infection and then they will ask you which of the following locations of lymph node are involved in this process. All right. And then you need to understand that, okay, it's the secondary follicle where the action happens. It is where proliferation of B lymphocytes occur. All right. So that's one way of asking question in the exam. So secondary follicle is super high yield. And primary follicle, although there are B lymphocytes, they are naive. All right. So primary follicle, they house the naive B cells, but this activation occurs in the secondary follicle. Super high yield from exam point of view. All right. Now, this is cortex. All right. So follicles are present in the cortex. Now, this is medulla. All right. This is medulla. And the reason between cortex and medulla is called paracortex. Now, paracortex is super high yield from exam point of view because it is the T cell zone. The cortex was the B cell zone, but the paracortex is the T cell zone. All right. So it houses T cells. So it is the site of T cell activation. Cortex is the site of B cell activation. Paracortex is the site of T cell activation. Super high yield from exam point of view. Now this is medulla. So medulla has these medullary cords and the sinus, all right? And you'll get numerous questions about medullary cords and medullary sinus. And the way they will ask you question is that medulla houses the macrophages, all right? So specifically the medullary sinus, all right? Medullary sinus has macrophages and reticular cells, all right? So medullary cords, they have plasma cells and lymphocytes. So they are packed with plasma cells and lymphocytes. But sinus, medullary sinus is unique because it has macrophages. All right, medullary sinus is unique because it has macrophages, and you'll get numerous disease where macrophage activation occurs, right? So the way they will ask you a question is, let's say a patient has tuberculosis, right? And you know that in tuberculosis activation of macrophages is so important, right? And then they will ask you, where are these macrophages located, right? And then you need to know that it's the medullary sinus which has macrophages, all right? So these are the most important structures of lymph node from exam point of view, all right? So it's not possible to go into every detail of the structure of lymph node, but from exam point of view, all you need to know is cortex is the B cell zone, paracortex is the T cell zone, and medullary sinuses, they have macrophages, all right? So these three are the most important things, but other stuff that we discussed in this slide are super high yield, but the most important ones are cortex, paracortex, and medulla, all right? Now, lymph nodes, like I said earlier, these are the sites where antigen presentation occurs and the activation of B cells and T cells occur, right? So we have talked about cortex as the B cell zone, and we have talked about follicles, all right? We have talked about secondary follicle and primary follicle. Secondary follicles are the active ones, primary follicles are the inactive. So primary follicles, they are inactive, they are dense aggregates of the naive B lymphocytes. But secondary follicles are pale and the active B cells, all right, the mature active B cells are present in the secondary follicle. This is super high yield from exam point of view. Now, paracortex, the T cell zone, all right. Now, we have talked about medullary cords and sinus. Cords, they're packed with plasma cell and lymphocytes, and the sinus, they're composed of macrophages and reticular cells, all right. So now let's talk about the most important lymph nodes in the body and their importance from exam point of view. Now, before we talk about individual group of lymph nodes, let's talk about why lymph nodes are really important from exam point of view. Now, in exam, lymph nodes will help you to come to a diagnosis, right? It helps to narrow down the differential diagnosis and it helps us to stage the disease. Let's say if there's malignancy, lymph nodes help us in the staging of the malignancy. All right. Now let's talk about diagnosing first. Now, talking about diagnosis, let's say there is a question about an ulceration in the anterior part of the tongue. Now, there are numerous causes of ulceration in anterior tongue. It could be squamous cell carcinoma, it could be Crohn's disease, it could be a simple aphthous ulcer, it could be a viral infection, right? So, how do you distinguish what is the diagnosis based on the examination finding? Now, anterior tongue drains into the submental lymph node. Now, if the submental lymph nodes are involved, and let's say if they are tender, mobile, then we can be pretty sure it's an infective cause. All right, if it's tender and mobile. Now, if that lymph node is hard, fixed, immobile, then we can think about the more sinister cause, right? Then we can think about malignancy. So this is how lymph nodes help us to differentiate between a benign and malignant cause from the examination finding itself, all right? Now, another important feature of lymph nodes is the spread of malignancy, right? If the malignancy spreads, then the lymph nodes will be involved. Now, the most important thing you need to understand that there are something called sentinel lymph nodes. Now, sentinel lymph nodes of different malignancy and different organs are different. But the concept that the lymph node which will be involved first, right? The lymph node which is initially involved when the malignancy spreads is the sentinel lymph node. So let's take example of breast. If the breast cancer spreads, the first lymph node that will be affected is the axillary lymph node. All right. So for breast cancer, the sentinel lymph node are the axillary lymph nodes. So these are also super high yield from exam point of view. Now let's look at individual group of lymph nodes. All right. Now I won't be talking about each and everything in this table. You can pause the video and read the table yourself, but what I'll be teaching you is the clinical importance. So like I talked about earlier, submandibular and submental lymph nodes, they're important for the diseases of the oral cavity. All right. So I talked about tongue in the earlier slide, right? Now let me give you an importance of the draining lymph nodes from the example of the lips, all right? The lower lip and upper lip, they have slightly different drainage, all right? The upper lip and the lateral part of the lower lip, they drain into the submandibular lymph node. The medial part of the lower lip, it drains into the submental lymph node, all right below the chin. Now, if there is a lesion in the most medial part of the lower lip, you can understand that the submental lymph node will be involved. Whereas if there is a lesion in the lateral part of the lower lip, the submandibular lymph nodes will be involved. This is just an example why lymph nodes are important from exam point of view. It will help you narrow down to the location of the disease, all right? It will help you understand the spread of the cancer, all right? That's why lymph nodes are super high yield. Now, if the deep cervical lymph nodes are enlarged, then you can narrow down that there is some kind of disease either in the posterior tongue, oral cavity, or there is some kind of malignancy of head and neck. All right. So if deep cervical lymph nodes are involved, this is what it hints you towards. Now, like I said earlier, the way lymph node examination help us to narrow down the diagnosis is by its characteristic. All right. If it's an infection, the lymph nodes will be very tender and mobile. So let's take example of infectious mononucleosis. Super high yield from exam point of view. In infectious mononucleosis, if you don't have lymphadenopathy, then it's likely that diagnosis is something else. All right. So infectious mononucleosis, lymphadenopathy must be present. Now, when you examine the cervical lymph nodes, if they're not tender, then your suspicion about infectious mononucleosis is wrong. All right. In infectious mononucleosis, the lymph nodes are going to be tender. All right. But let's say if it's a malignancy, then the lymph nodes will be non tender, immobile, fixed, hard. All right. So this is how you can distinguish whether it's infectious mononucleosis or it's a malignancy. All right. So another most important lymph node from exam point of view is the left supraclavicular, the Virchow node, all right? And it is involved in abdomen and pelvis malignancy. That's why it's super high yield. Now, another highly tested question in exam is tuberculosis, all right? Now, in tuberculosis, mediastinal and hilar lymph nodes are involved. So whenever you have a patient with cough and hilar lymphadenopathy, you can narrow it down to these causes, all right? You can narrow it down to TB, sarcoidosis, malignancy, and granulomatous condition, right? So TB and sarcoidosis are the granulomatous conditions. So if there is cough and other respiratory symptoms, and if these mediastinal and hilar lymph nodes are involved, then you can narrow it down to these diseases. All right. We talked about breast cancer, right? And how axillary lymph nodes are involved. Now, another super high yield lymph node is epitrochlear. Whenever you have involvement of epitrochlear lymph node, you can definitely choose the option of syphilis, all right? Super high yield. If epitrochlear lymph nodes are involved, you can narrow it down to syphilis. Now let's look at other important lymph nodes of the body, all right? So celiac, superior mesenteric, and inferior mesenteric lymph nodes are involved in disease of the bowel. All right. So if there is a malignancy of colon, let's say if there's colon cancer, then you need to understand that these lymph nodes will be involved. Now, depending on which part of colon, the lymph nodes involved will be different. All right. And these lymph nodes have to be removed if there is a surgical procedure. All right. So you need to understand that. Now, the most important thing from exam point of view is gastric cancer. All right. In gastric cancer, the periumbilical lymph node. All right. So the periumbilical lymph node. So it's present here. All right. So periumbilical, that means around the umbilicus. All right. So if the lymph nodes around the umbilicus are involved, and if you can feel that during examination, then you have to be suspicious about gastric cancer. All right. Super high yield, Sister Mary Joseph lymph node, periumbilical lymph nodes, super high yield. So let's assume there is a mass in testis or ovaries. The lymph node involved will be para-aortic. Although location of testis is here, you might be wondering why there is para-aortic lymph node involvement, right? So for this, you need to understand that testis, it develops here, all right, as an intra-abdominal organ. Then it descends down here to the scrotum. That's why even if there is involvement of testis, which is located here, the lymph node involved will be para-aortic, super high yield from exam point of view. If there is any malignancy in the testis, they will spread to the para-aortic, all right? They'll spread around here, around the para-aortic lymph node. Now, another really important lymph node is the external iliac, all right, and the internal iliac. So external iliac and internal iliac, they are present around the iliac artery, so somewhere around here, all right? Now, if there is a malignancy of cervix or let's say vagina, right, they will spread to the internal iliac, all right? So that's why you need to understand the importance of these lymph nodes. They help us to identify metastasis, the staging of the malignancy, all right? So super high yield. Now, another really important point from exam point of view is the involvement of anal canal below the pectinate line and involvement of anal canal above the pectinate line, all right? Now, if there is any disease condition below the pectinate line, it will drain to the superficial inguinal lymph node. But if there is involvement above the pectinate line, it will involve the internal iliac. All right, super high yield from exam point of view. Now, another highly tested question is the involvement of the foot. All right, if the medial foot is involved, it will drain to the superficial inguinal lymph node. So if there is any infection of the medial foot, you need to understand that it will drain to the superficial inguinal. Now, if there is involvement of the lateral foot, all right, then the popliteal lymph node will be involved. All right. So the posterior calf and the lateral foot, they drain to the popliteal. But the medial foot, it drains to the superficial inguinal. This is super high yield from exam point of view. All right. Now, this is a small mnemonic. The popliteal, the letial sounds like little toe. All right. And little toe is present in the lateral foot. All right. So always remember lateral foot involvement, there'll be drainage to the popliteal. But if medial foot is involved, it will drain to the superficial inguinal. All right, super high yield from exam point of view. Now, another important point that I want to repeat again is the anal canal. If there is any disease condition below the pectinate line, the superficial inguinal lymph node will be involved. But if there is involvement above the pectinate line, the internal iliac lymph nodes will be involved. All right, above the pectinate line, internal iliac. So now let's talk about spleen. So first, we need to know the important function of spleen. So the most important function of spleen is to filter and clear old and misshaped RBCs and platelets. And another function of spleen is similar to the lymph node, all right? It initiates the humoral response. So you need to understand how spleen clears and filters misshapen RBCs. So misshaped RBCs, they cannot bend or they are not flexible like the normal RBCs, all right? And in spleen, there are these really narrow arterioles in the red pulp. And if the RBC is abnormal, it cannot squeeze through these narrow arterioles, all right? And when they cannot squeeze through, they get stuck and they are cleared by the macrophages, all right? That's how misshapen or old RBCs and platelet are cleared via spleen. Now, similar to lymph node, it is really important in initiating the humoral immune response via B cells and T cells. Now, another really high yield point from exam point of view is the location of the spleen. The spleen is located in the left upper quadrant, all right? And if there is a question about trauma, and if the impact is on the left side of the body, we have to be suspicious about the splenic rupture, all right? And if there is particular mention of the fracture of 9th, 10th, and 11th ribs, then you have to be more careful about the risk of splenic rupture, all right? So let's look at the structure of the spleen. So the structure of the spleen is divided into red pulp and white pulp. So here I have highlighted this small section which shows both the red pulp and the white pulp. all right? So this area outside is the red pulp, all right? And this whitish peel structure is the white pulp. That's why they are called white pulp and the red pulp, right? So I've highlighted this structure which shows both the white pulp and small part of the red pulp here, all right? The white pulp is divided into follicles, or which are also known as the B cell zone, all right? The follicle are known as the B cell zone, and there is a T cell zone as well. Now you can imagine that B cell zone or the follicles have a lot of B cells, right? That's why they are called B cell zone. And the T cell zone has huge storage of the T cells. Now the follicle has a germinal center where the major activity or the major activation of the B cell occurs. So this is the germinal center where the active B cells are present, all right? And this is the marginal zone. Now let's look at these structure in more detail. So the white bulb is the reason where antigen filtration and presentation occurs. Now you can imagine that the white bulb has both the B cell zone and the T cell zone. So it's obvious that antigen presentation occurs here. All right. Now, like I said, this lymphoid follicle is the B cell zone. It has a lot of B lymphocytes. Now, T cell zone is also called periarteriolar lymphatic sheath. All right. And this marginal zone contains the macrophages and specialized B cells. All right. So when B cells are differentiated into effector cells, they're present here. So the specialized B cells are present in the marginal zone, and it contains a lot of macrophages. Now you can imagine that antigen capture, all right, occurs here. Why? Because it has a lot of macrophages and B cells. So antigens are captured here and then they get presented and the B cells are activated in the germinal center. Now let's look at the red pulp. So red pulp is the area here, all right, outside the white pulp. So the white pulp is present more centrally and the red pulp is more on the outside of the white bulb, all right? So this is the red cell zone, all right? And it is involved in the capturing of the abnormal RBCs and platelets. Like I talked earlier, if the RBCs are misshaped or if they are old, they cannot squeeze through the narrow arterioles, all right? And then they are captured by the macrophages and they undergo phagocytosis. Now, splenectomy. This is super high yield from exam point of view because you'll get a lot of questions about splenectomy. So the most common conditions for splenectomy are trauma, sickle cell disease, thalassemia, hereditary spherocytosis, and refractory ITP. We won't be going detail into the absolute indications and, in detail of these diseases because it's not the scope of this video, all right? So these are just common conditions where splenectomy is necessary. Now, super high yield point from exam point of view is how our body adapts or what are the changes in our body after splenectomy. This is super high yield. Now, spleen is such an important organ for our immune system, right? It's a really important place where antigens are captured, where bacteria are destroyed, all right, where a lot of phagocytosis by macrophages occur. Another reason why spleen is important because it contains a large pool of B cells and T cells. And when we remove this large pool, there'll be deficiency of B cells, all right? And when we remove this large pool of B cells, obviously the IgM production is going to decrease, all right? Now, when IgM production is decreased, obviously the complement activation won't occur because we don't have this IgM, all right. And IgM and IgG antibodies are one of the most important antibodies for complement activation. Without complement activation, there won't be C3b opsonization because remember, C3, complement C3b is an opsonin, all right. It tags the cell or abnormal cells and bacteria so that the macrophages and natural killer cells recognize them and they can phagocytose them, all right? So there is decreased clearance of opsonized bacteria because there's no opsonin, all right? There's no C3p. So this increases the susceptibility to infection, especially by the encapsulated bacteria, because clearance of encapsulated bacteria depends on opsonization and phagocytosis. Without opsonization, the macrophages and natural killer cells, they cannot recognize bacteria, all right? So phagocytosis will be impaired. And this is one of the most important defense mechanism to destroy the encapsulated bacteria. So without spleen, there's increased risk of encapsulated bacteria. Super high yield from exam point of view, all right? They love to test you about decreased IgM production, decreased complement activation, decreased opsonization after splenectomy. So you need to understand this concept. IgM production is decreased because there's decrease in B cell, all right? And without IgM production, there won't be enough or adequate complement activation, decrease C3b, and without C3b, there won't be opsonization. So now let's talk about post-splenectomy findings. So these are highly tested questions in the exam, all right? They will love to ask you about post-splenectomy finding in the exam. So let's look at the post-splenectomy findings in the peripheral blood smear. So the first high yield finding is the Howell-Jolly bodies. So Howell-Jolly bodies are nothing but RBCs which contains the nuclear remnant. So normally RBCs don't have any nuclear remnant, but when they are present, they are called Howell-Jolly bodies. So normally spleen clears any RBCs with the nuclear remnant, but after splenectomy, this function is impaired. So you'll see RBCs with nuclear remnant or the Howell-Jolly bodies in the peripheral smear after the spleen is removed. So this is Howell-Jolly body. All right, this is an RBC with a nuclear remnant. All right, another high yield cell that you'll see in peripheral blood smear is the target cell. So target cells are RBCs which look like this. All right, so this looks like a target sign. That's why they are called target cells. So they are nothing but RBCs which have mismatched RBC volume and surface area. All right, normally target cells, when they form, they are removed by the spleen. But like I said earlier, after the spleen is removed, this clearance function of the spleen is not present, right? We don't have that feature. Then target cells and Hall-Jolly bodies, they appear in the peripheral blood smear. Super high yield from exam point of view. Now, another finding in peripheral blood smear is thrombocytosis. Now, you might be wondering why there'll be thrombocytosis. It's because of loss of function of storage, all right? Spleen normally stores a lot of thrombocytes and B cells and T cells, all right? When this sequestration feature of the spleen is gone, you'll see thrombocytosis, all right? Because there's no sequestration of the thrombocytes in the spleen. Another feature is lymphocytosis. Again, this occurs because of loss of sequestration. Now, you might be wondering, earlier I told there is loss of large pool of B cell, but here I'm saying there'll be lymphocytosis. You need to understand that this loss of large pool of B cell is loss of large pool of active B cells. In the blood, you don't have active B cells. They are mature B cells, but they are not active. The activation occurs in the spleen, all right? When this loss of active B cells occur, there is decreased IgM production, all right? So remember, it's the follicles where activation, proliferation of the B cells occur, right? And without spleen, this follicle is lost. So that loss, that loss of large pool of B cell means the loss of active B cells, all right? So you need to understand that. So now let's talk about vaccination, all right? And this is vaccination against the encapsulated organism when you're undergoing splenectomy. So if this is an emergency splenectomy, you do this vaccination after the splenectomy, all right? So post splenectomy. But if it's an elective splenectomy, let's say for sickle cell disease, or let's say for thalassemia, then you need to give this vaccines 2 weeks before the splenectomy, all right? So you give vaccination against the encapsulated organism. Like I said earlier, encapsulated organisms are destroyed by opsonization and phagocytosis. Without spleen, there's decreased IgM production and there'll be decreased opsonin, all right? So there's a risk of encapsulated organism infection. So you need vaccinations against strep pneumo, all right? So you administer pneumococcal vaccine against strep pneumonia. Then against Neisseria meningitis, you need meningococcal vaccine. And for Haemophilus influenza type B, you need the vaccine against it. All right. So these three are the most important vaccination for encapsulated organism. And this is super high yield from exam point of view. Now let's do some USMLE style questions. So let's look at this first question. So a 32-year-old man is admitted to ICU due to sepsis. His past medical history is significant for a motor vehicle accident 4 years ago, for which emergency laparotomy was done due to internal bleeding. All right, so there was a ruptured organ and he needed emergency laparotomy. Since then, he has had multiple episodes of infection due to Streptococcus pneumoniae. Currently, he's in sepsis and his blood pressure is 80 by 40, so he's in shock. There's tachycardia, and the blood culture obtained on admission grew Streptococcus pneumoniae. So he has had recurrent strep pneumo infection, and again, there's Streptococcus pneumoniae isolated in the blood. All right. Impairment of which of the following mechanism most likely contributed to this recurrent infection? Now you need to understand that the patient probably had splenectomy. All right. So there was internal bleeding because of ruptured organ. Since then, there is recurrent encapsulated organism infection. So most likely there was splenectomy. So what function was impaired after splenectomy? So let's look at the options. Is it decreased complement production, or impaired T cell activation, decreased opsonization, or decreased interferon release? Now, you might be confused with option A and C because I said complements are needed for opsonization, especially C3b. So you might be confused with decreased complement production, but you need to understand that complements are produced in the liver. The activation needs IgM. All right, so antigen antibody triggers the activation of complements, but they are produced in the liver. So option A is wrong. Now, decreased opsonization, all right, this is the answer, and we just talked about it, all right. Without spleen, the active B cells are decreased, and there'll be decreased production of IgM, without which there won't be activation of complements and there won't be C3b, which is one of the most important opsonins beside IgG. All right, so the right answer is decreased opsonization is causing recurrent encapsulated organism infection in this patient. All right, so now let's look at another question. A 22-year-old man comes to your office because of 5-week history of cough, weight loss, fever, and night sweats. Now, he migrated from Nepal 8 months ago. His temperature is 100.5. Physical examination shows a thinly built man with enlargement of right supraclavicular lymph node. Chest and abdominal examination are normal. However, PPD test is positive. Biopsy specimen of the supraclavicular lymph node is most likely to show causative bacteria in which of the following lymph node locations? So if you remember what I taught earlier, tuberculosis causes involvement of the macrophage. All right, macrophages engulf the mycobacterium. So you need to understand which of the following location has excessive macrophages. All right. So let's look at the option. Is it the primary follicle? No, right? Follicles, they contain B cells. Is it the paracortex? Paracortex contains T cells. Now, the right answer is medullary sinus, because if you remember, medullary sinus houses macrophages. All right, so the right answer is medullary sinus. Thank you. Hope you enjoyed the video.